And good morning, everyone. Thank you for joining us. For those of you who just joined us, I'm Ankit Sanghvi. I'm the Executive Director with the Texas Health Institute and proud to be a co-lead on the Texas Primary Care Consortium. You have joined us today for our third webinar in our series as a consortium, which is Balancing Pandemic Response and Sustaining Primary Care. We have an amazing set of presenters and panelists joining us today, really lifting up stories of success and sharing lessons as we navigate through the pandemic. With strong primary care shining through the story. So again, I'm excited and looking forward to today's discussion. But we won't be doing this as the consortium without the support of our amazing partners at the Texas Academy of Family Physicians and the Texas Medical Association, who join our other partners, which is AmeriGroup, SANA, TMF Health Quality Institute, the Texas chapter of the American College of Physicians, Catalyst Health Network, Path Advantage, and St. David's Foundation. Again, we truly appreciate their support and joining us in our mission of advancing primary care. To set the context for those of you who may be new to the consortium, it's a statewide collaborative with a mission to advance equitable, comprehensive, and sustainable primary care for all Texans. And it's an initiative jointly led by Texas Medical Home Initiative in partnership with the Texas Health Institute. For those of you who may know Texas Health Institute, we serve as an independent, nonpartisan public health institute in Texas and are proud to collaborate with Dr. Sue Bonstein as the Executive Director for the Texas Medical Home Initiative. And it's been a partnership that has grown since our first annual summit started back in 2012. Our work at the consortium is led with a theory of change that we look at it in a three-pronged approach. First is about educating stakeholders by sharing best practices, lessons learned, and replicable tools. It comes in many forms through our online repository and resources that we share through the Texas Primary Care Consortium website, but also our annual summit and this webinar and other education opportunities that we continue to offer and need to grow further. Supporting that is activating transformation efforts across the state by facilitating opportunities that build, strengthen, and lasting partnerships for shared and sustainable impact. And we cannot move the needle without systemic change. That's where our third strategy on transforming system transformation comes into play, by the consortium creating spaces for dialogue and action to generate a shift in healthcare system through policy and systems change initiatives. Again, I'm excited for today's discussion. This in many ways is in response to the feedback that we received from our participants in the first two webinars, and really to shine a light and bring attention to the work going on here in Texas. And I couldn't be more excited to introduce today's panel. It's both an honor and privilege to be able to do this today. Joining us today is my dear friend and colleague, Dr. Sue Bonstein, the Executive Director for the Texas Medical Home Initiative and co-lead on the consortium, who will help facilitate today's discussion, really contextualize. But the excitement that both Sue and I share is for the panelists that we have joining us today. The first group that we have is Dr. Norman Chenwin, a family physician and the founding CEO of the Austin Regional Clinic, and Dr. Anes Dagestani, internal medicine physician by training and chief executive officer for the Austin Regional Clinic. Joining Dr. Dagestani and Dr. Chenwin is Dr. Ben Wilson, who serves currently as the associate chief medical officer and COVID coordinator with Waco Family of Medicine. So to help get us kick off, I'm going to stop my screen share and invite Dr. Chenwin and Dr. Dagestani to lead us into today's presentation by sharing about the Austin Regional Clinic, which is a 380 physician multi-specialty medical group here in Central Texas, serving about 600,000 Central Texans across 14 cities and 4 counties. Dr. Chenwin, as I mentioned, is the founding CEO of the clinic, and Dr. Dagestani serves currently as the CEO and president of the Austin Regional Clinic, along with the president and CEO of Covenant Management Systems, which is an Austin-based organization that delivers a full spectrum of medical group management. Again, very excited, Dr. Chenwin and Dagestani, to have you join us today for today's webinar. And Austin Regional Clinic is an organization that's very near and dear to me and something that I look up to when I think about what does high quality primary care mean. So again, thank you for joining us today, and the virtual floor is yours.
Okay, well, thank you very much for having us, Sue, and Keith, thank you. I appreciate the presentation. I'm going to go ahead and share my screen. Give me a second. I went through this exercise. This is kind of like medicine. Learn one, do one, and teach one. So if anybody needs advice on how to handle this in the future. So I think I have my screen shared. Do you see it accurate on your side? Okay.
Yes,
Yes,
it
sir.
looks good.
Okay, so appreciate everybody's time. Norman, do you want to go ahead and kick us off?
Sure. So to start off, just to give you some perspective about Austin Regional Clinic, we are a multi-specialty group, but we're largely built on a platform of primary care. And of our 380 physicians and advanced practice providers, about 65%, close to 70% are really primary care. And then we have added specialties, and we're not the Noah's Ark version of a multi-specialty group. We don't have all specialties. We have some of the major specialties that help us manage care. We work with specialists in the community. We're part of the greater Austin community. We cover, essentially, we have facilities in 4 counties, but we really cover 5 or 6 counties in and around Austin. We had 1.4 million patient visits last year. We have 2,300 employees, including our providers. We cover about 2,500 square miles. So just to give you a sense of the scale, the group was founded in 1980. We have 33 locations. This map gives you a sense of that. And of late, we've been opening facilities out in the smaller communities that used to be 200, 400, 800 people, and now 10,000 people. So 14 cities in this area. And the group is physician-owned and physician-governed. Next slide. So, and next slide, just give you a sense of what our facilities look like. Next slide. And then I think, Anas, do you want to go ahead and take it from there?
Sure. So I think we were all in the same boat when the pandemic started. Most of us started hearing the news, I think, late November, maybe December, of what's happening in China, then Italy. But where it all hit is 3rd week of March. Actually, when I look at our visits and everything was going normal almost until the 3rd week of March, and literally overnight, about 70% of our visits disappeared on the primary care side. On the specialty side, because of the cancellation of many procedures, many specialty went down to 0, actually, procedure completely for a few weeks. There was a lot of panic. Obviously, we didn't know all the signs then. We didn't know what we know right now. So I think what we try to do is follow a multidisciplinary group. So I'll walk you through the details, maybe more on a deeper level. So we've had a daily huddle with a lot of our operations and leadership team. We had a physician call twice a week on Monday morning while our physicians and nurse practitioners and PA driving to work, and then at the end of the day on Thursday. And part of it was to share the information. Part of it was to get feedback from them. But if you remember, then a lot of us, luckily, we forget sometimes about those things. But there was a lot of, I've heard, this group did this in California. I've heard, of an anesthesiologist who got really sick in this area. A friend of mine told me that they're closing their clinic. A friend of mine told me that they're, so we had to quickly, address a lot of those concerns and be ready to deal with it. We've engaged our purchasing department team also to try and get ahead of it, to get PPEs and supply ahead of time, basically. We had to do a lot of investment in telemedicine. Before 3rd week of March, we've done 0% telemedicine in that realm as an extension to the primary care physician or to the specialist. And then, within 7 days, probably about 70 to 80% of our visits were done online, both primary care and specialty, basically. So I think our objective was to keep the patient safe. And you can keep the patient safe 2 different ways. You can keep the patient safe by, by keeping them out of the ER. So we wanted to keep our patients safe by being out of the emergency room and the hospital, because the emergency room and the hospitals were overwhelmed. We wanted to keep them safe by maintaining the connection with the primary care physician. We also wanted to keep our staff safe. So we had to really implement a lot of processes very quickly. And there wasn't a cookbook for this. None of us, I think, Norman, you read a book about the flu pandemic early enough in our pandemic, and trying to just get a sense of what's going to happen. There wasn't a cookbook. It wasn't something that we've dealt with before at this scale. Many of us have had mini scrimmage with Ebola a few years ago, with measles outbreak, with pertussis outbreak, but those were contained small numbers, and those are known viruses with known protocol. So we had to really almost refine our process every single day. You hear the term there's no such thing as over communicating. This is really held true in this situation. I think we've had daily emails. We had calls with our center managers twice a week, as I said, with our physician twice a week. We've had some town halls inviting all of our staff to attend Zoom calls. Obviously, at that point, everything was a call or Zoom to be able to do that. And then the transition from telemedicine, and also our ability to transition a lot of our tools to be online. At some point, most of our scheduling for the visits were, in the pandemic, early in the pandemic, all of those were done online. We've had to make some tough decision about physician salaries, and we've actually went through a period over 3 months where we made adjustment to physician salaries every 2 weeks, and we've had to engage the physician and the leadership, and it went really well. We've worked with our staff on voluntary furloughs, and that was actually very well received, rather than us trying to figure out what's the appropriate staffing measures. Some of our staff were dealing with supporting their kids at home since schools were out. So we've actually done 3 rounds of voluntary furloughs, and actually all 3 were oversubscribed to. So we had to go back and say, I know you've asked for a furlough, but would you consider working actually? Because it was really engaged, and our HR department did, a great job engaging the staff. Refill protocols, we've had to modify and relax it. We didn't want our patients to, you have a diabetic that they're due for follow-up. Typically, if we haven't seen them in 6 months, we really ask them to come back before we refill the medication. But we had to relax all of those protocols to keep the patients safe and to keep them with the medications. And then, quickly we had to pivot and get ready to figure out how we do vaccination and how we do mass level testing as well. Looking at the last 2 years, I think we've done about 200,000 COVID tests and close to 200,000 COVID vaccines at the same time. Anything to add, Norman?
No, I think, again, you can't overestimate the importance of communication. That's what held the organization together as a team. I think the voluntary furloughs, we made it real clear to our employees that the last thing we were going to do is let anybody go. Our initial financial expectations were almost catastrophic. We saw ourselves losing millions and millions of dollars. And fortunately, it didn't work out that way. But there was anxiety at every level. And we did have physicians who needed counseling. There were physicians saying, well, I don't want to go in there. I don't want to expose myself, my family, and so on. We took physicians through how they could protect themselves and staff and continue to see the patients and do well. We also had, the flow of patients had to change. And of course, there was a lot of delivery of medicine, either telemedicine or in cars in the parking lots when we'd bring patients in, depending on what was needed for a physical exam. I think my pride about the organization, we never closed a clinic. We never turned a patient away.
Yeah, the other thing I would add also is we worked very closely with local health authorities and with the other organization in town, and that was helpful because we had a better understanding of everybody else's challenges as well. So we worked with the the medical county here with the health authorities, with the state and the city health authorities, and with the larger hospital-based system in the city. That was an opportunity where actually we all had weekly calls with everybody on the call, which helped us all stay coordinated. Because unfortunately, some of the smaller practices did struggle, unfortunately, securing PPEs or staffing. So we've also seen a significant increase in our new patients as an organization because of limited access outside. So lesson learned, I think it was a 24/7 undertaking. I think there were many times where we've had calls at 5 and 6 a.m. in the morning, and at the end of the day, it was weekends, Sunday, Saturday, because there are a lot of anxiety and also a lot of new recommendation. We went through, CDC went through a rapid firing at some point where you'll have a recommendation on Monday, but based on changes, you'll have a different recommendation by Tuesday, then different one by Thursday. So we've had to learn that. Ongoing communication, what we didn't cover is communication with our patients. So we took some of our nurse practitioners team during the peak of the pandemic, and they actually wanted to staff a COVID hotline, basically. So we've had some of our nurse practitioners in primary care staffing a COVID hotline. And also we work with our marketing department, where at some point we were sending our patients a brief weekly update on workflow, what do we know about the pandemic? Because there are a lot of, based on what news channel, what social media, there were a lot of conflicting information. So we tried to keep our patients informed. Teamwork is critical. Fairness, we didn't all agree on the same solution. We've had a few of our physicians and staff who felt that we should have handled things differently. We've had to all get on the phone and call and spend no matter what time it takes to work through the process, to work them through it, or to respectfully disagree when we felt about it differently. And that kept the group very solid and strong. Having the relationship between the primary care physician and the patient was critical, because the patient didn't have to see another doctor. And also keeping the specialists engaged with a primary care physician, keeping that loop was critical to what we think made us successful. Basically, you can never underestimate the culture of the organization and ongoing engagement. And this is Norman's statement at the end: we don't want to do this again. I think it's been over 2 years. None of us want to go through this ever again. So, Norman, any closing comments?
No, I think, this is a primary care discussion. Without primary care, of course, none of this could have happened. And we're fortunate in having such a large platform and being able to cover the entire community. It really was extremely helpful and successful. And I think we got a lot of recognition from the community. We were often first in the community in implementing various measures. We were very much engaged in trying to get our patients immunized once the vaccine was available. And we actually set up mass immunization events in our administrative building where we had the space.
Okay, so I think that's all what we have slide-wise. Appreciate everybody's time. I'm going to stop sharing my screen and turn it back to you.
Thank you, Dr. Dagestani and Dr. Chenwin. Again, thank you for joining us and very practically walking us through what the journey has been. And I cannot emphasize the importance on communication, both internally and externally. But what this has really been is the perseverance of primary care is what has shined through the story. So really appreciate you sharing that. And that really sets the context and stage for Dr. Wilson as our fellow presenter again joining today with a similar, I would say, perspective, but in a slightly different context, given Waco Family Medicine is a federally qualified health center and really designed to primarily serve the underserved populations in the McLean and Webb County. Well, actually, let me just make sure. McLennan and Dr. Wilson.
Bell County, yeah.
Yes, sir. Bell County. So again, thank you, Dr. Chenwin, Dr. Dagestani. We will have enough time for questions that attendees may have towards the end. But now I would want to again invite and let Dr. Wilson take the virtual floor to walk us through the journey from Waco Family Medicine's perspective. On to you, Dr. Wilson.
All right, thank you so much, Ankit. Share screen. All right. And I think that should be good. Again, thank you all for the welcome and for the opportunity to participate. I'm an internist, originally from Corpus, but practicing here in Waco, Associate Chief Medical Officer with Waco Family Medicine and also COVID coordinator. All right, so just a word similar to, there'll be some overlap in the presentation here between what I'm saying and the gentleman from Austin Regional. And so just a few fast facts about our organization. I won't read all of this, but we have 14 primary care sites. We do have on-site pharmacy and dental, and we provide some hospital inpatient care. We're a community health center, which means we receive a 330 grant to provide care to a poorer population. We do house a residency program. The Waco Family Medicine residency is actually one of the top 2% of programs nationwide, we're proud to say. And so here are some other fast facts about our organization. We have access to, or we provide access to multiple subspecialties on site, despite patients' inability to pay and the percentage uninsured patients that we have in our population. That is either through primary care docs in our organization that have sort of taken on some additional skill set to be able to competently treat diseases such as hepatitis C or HIV, or we'll have subspecialists volunteer their time and come in and staff a resident clinic once a month, an example of like cardiology clinic. All right, so as has already been iterated with Anas and Norman, we were in total panic mode, just like everybody else when this initially started. Visits were down. We had daily department head meetings. There was a shortage of PPE, and I think the pandemic kind of exposed our organizational vulnerabilities. And the big question was, how do we provide care, both COVID care and chronic care at the same time? Everybody was dealing with that dilemma. I think in the mayhem, just overall, I almost have to try to kind of harken back in my memory as to what everyone was thinking and feeling at that time. And it was almost surreal. There was kind of this sense of we're all going to die. It was terrible. But we tried to fight through the panic and take action. And so we quickly instituted COVID tent clinic, outdoor care, much like many organizations, telehealth. We, like the guys from the ARC, the folks from the ARC, did not have telehealth instituted before the pandemic, and so we had to start that up pretty quick, and luckily we're able to do that. We started offering remote work for staff members that qualified for it. In-house COVID testing. Initially, we were actually using an outside lab, but they is kind of interesting story. When the initial wave hit in summer of 2020, they stopped testing because they were getting so far. I think all labs were getting so far behind in processing their specimens that they just said, sorry, we can't do it anymore to all their clients. And so facing the prospect of not being able to test at all, luckily we had been working to onboard antigen testing in all of our clinics. We happen to have the Sophia 2 analyzer already present in our clinics doing strep and flu testing pre-pandemic, and we wanted to be able to provide COVID testing through that analyzer now that the manufacturer had produced that test, the COVID test specifically. And so on a Friday, we learned that this particular lab was dropping us, or was no longer allowing us to do COVID testing with them. We didn't have really, I mean, I think all labs were in the same, outside labs were in the same ballpark. And so we had to switch immediately to in-house COVID testing. Well, luckily, we were kind of far along enough in the process to where we were close. We're kind of at the edge of the diving board. And so we worked that weekend to institute it by the following Monday so that we would have no interruption in COVID testing for our patients. So that was, it was like something from a movie. We were all sweating bullets. And so other adaptations, you know, curbside pharmacy, chronic care management, and then later on, like a lot of folks, COVID vaccines and the COVID oral agents, Paxlovid, Molnupiravir. Very fortunate to be able to participate in the HRSA COVID programs, the vaccine program and the therapeutics programs, and be receiving our own supply of Paxlovid and Molnupiravir directly to our pharmacy from the feds because we're a community health center. Just a little further background as I'm talking here as to what we've experienced here in McLennan County. It has been difficult to say the least. And so it's been horrible throughout Texas, being in the South and with the decreased proportion of patients that are fully vaccinated. But for whatever reason, we definitely received our fair share of cases here in McLennan County and then resulting hospitalizations and deaths. And so the purple line is the curve for McLennan County. Over time, you can see that the Delta and the Omicron waves are clearly labeled. And then the orange line is the rest of Texas with a small typo there, it looks like. So essentially, again, for whatever reason, we had double the cases per day per capita during the Delta and Omicron surges here in McLennan County that the rest of Texas did. And it was, the pandemic has not been kind to us. Challenges that we face that I think are worth discussing fall into two categories. One is challenges for patients, and the other I think of as challenges related to staffing at all levels of the organization. So first, challenges to patients are subdivided into really, I think, common to all patients and all organizations, but I think of it a whole lot in community health center context and general lack of resources or access to transportation or lack thereof, and then lack of access to technology. And so specifically the access to transportation played out in the when we started offering testing and vaccines. With the just suffice it to say that it's been difficult testing and vaccinated patients in an efficient manner while attempting to accommodate those with unreliable transportation. And you really need to receive as much care as possible close to home. Specifically with the vaccines, the question has been, you know, how do we get vaccines out in the community, out in close to our patients and close to where they live, while minimizing wastage using 10-dose vials, and have staff continuing to provide normal non-COVID vaccine care. So for example, at our MLK clinic, can we offer vaccines and testing out there and still have them, have them give a vial of 10 doses in a given morning, for example, or a half day, and then still have the nurses do everything that they normally do. With flu season, they're single dose vials. Well, they can give a quick single dose vial and then go back to what they were doing. With 10 dose vials, it's a little bit different. And so that's been a challenge. This at some point was actually has felt like a problem for an MIT graduate, and I felt horribly inadequate to solve it. But we have, at the end of the day, we have cheated more to the side of mass vaccine and mass testing sort of operations and clinics. And while still kind of doing a hybrid approach, particularly with our furthest outlying sites, having some testing available outside, maybe even in their cars, and some vaccines also available for those folks that can't make it to our mass testing and mass vac sites. It has been difficult to accomplish all of this. Particularly these outlying sites when you have a 50% positivity rate and you're having to jump in and out of clinic and everything and don and doff PPE. So it's been challenging. Access to technology, our patients just don't have quite as much access to technology as the average folks on average. This translates into limited, really functional use of the patient portal. We have Epic as our EMR, which means that their patient portal is called MyChart. And so we have, maybe 30% of our patients are actually enrolled in MyChart, despite our best efforts to enroll folks. And even among those, we have maybe a third or half of them that have true functional usage. And so that has been really difficult when we have instituted video visits, which occur through, which we chose to implement through Epic. Obviously, you have to have functional MyChart usage or patient portal usage to be able to accomplish those. Or maybe it's not obvious, but that's the way it was set up. And so they didn't have as much access to video visits. Thank goodness for phone visits, that those are an option. But then the access to technology has really cramped our ability, and lack of enrollment in MyChart has cramped our patients' ability really to contact us during surge times. We have so many staff members out during surge times because of COVID leave, that a lot of times there just simply are not enough staff to answer all the phone calls. So the patients that are on MyChart and have the technology at home to do that, to access us through MyChart, have a clear advantage over those that are having to go kind of the old school route of picking up a telephone to call us. And at one point, just one fast fact, statistic, during the height of the Omicron surge, we have a digital phone system. And so we're able to see call volumes and how many were actually answering. And so one of our busier clinics was only able to answer approximately 30% of their phone calls during the height of the Omicron surge, just because of lack of staff available to answer those. And so MyChart users have a clear advantage because they can send messages directly. Again, a lot of our patients may not have internet though, so MyChart may not be an option for them. Challenges related to staff. I think these are at all levels of our organization. We found, first of all, with roles and responsibilities, that the organizational chart, or the org chart, needed to be clarified. Crisis reveals a lot about yourself as a person and as an organization. And I think we found that people were in some cases in the wrong role, or maybe were reporting to the wrong person, or maybe didn't have the appropriate supervision. And so that stressor of the pandemic, applying that selection pressure, I think helped us in a positive way clarify some of our organizational chart. Of course, the understaffing has probably been the most difficult aspect of the entire pandemic ordeal in hindsight for many organizations, and we're certainly no exception. We were already understaffed coming into the pandemic for various reasons, and so with COVID leave and staff turnover, it was even worse. It was a recipe for disaster. We have had heartfelt conversations about how much should we be paying our staff, and have given people raises that needed to have them. And then finally, we, during the pandemic, brought in an associate director of HR specifically to coordinate interviewing and hire mass quantities of staff, which is essentially what's been needed. So that's one example of just kind of higher level staffing adaptations that we've made to keep up for the need, with the need for staffing. We, like everyone else, has felt the tension of how to allocate staff. Just a reminder, that we've been hit so hard with cases and hospitalizations here in McLennan County. And so, there have been, during the Delta surge in particular, but an Omicron surge as well. I mean, the hospitals were over capacity. There was alternate care site planning going on, and hospital administration was sort of collectively exasperated. And so all of outpatient care here in McLennan County was asking the question, what can we do to help, and how much care do we need to divert to COVID care at the expense of non-COVID care? We were just not quite as fortunate, I guess, as Austin Regional in their clinic closures. We were having to close about 1.5 clinics out of our 14 per day to consolidate staffing to still be able to provide enough COVID care to meet the demand, and just to consolidate staffing for the sake of being able to have a functional clinic, in the clinics that were open. Very painful at times because we didn't, like I said, we didn't have the staff a lot of times to call patients to notify them that, their providers were shunted to COVID care. And so therefore their appointments needed to be rescheduled. So we would have kind of a very unfortunate number of patients at the peak of the surges that would come in, and we just have to say, I'm sorry, your doc is not here right now. He's gone to the COVID tent to provide care, and we're just going to have to reschedule your appointment. Sorry, we were unable to call you beforehand. It was very, very difficult with staffing shortages and allocation issues. Staff wellness, I think it's worth mentioning, that I think the pandemic has put a microscope a little bit on what we do as organizations for staff wellness. And it's a little bit of a catch-22 with the pandemic, because the very thing that occasioned the problem gave us little time to remedy it. So I think we're still a little bit behind the curve in this area, but we're having active conversations about what kind of organizational resources do we devote to staff wellness. So now is kind of part two of my talk here with a few minutes left, I think. And these are reflections on, what the pandemic has meant for our organization, how sustainable is primary care here at Waco Family Medicine going forward, based on the adaptations we've made or need to make. And so I'm going to move from concrete to abstract. So one concrete change that we've made that we may continue in the future is we might continue to provide care outside in our outdoor clinic, our tent clinic, seasonally during flu season in perpetuity. I think that it is, for us, at least the way we have it designed, it's more efficient manner of providing cough and cold care. I think the patients like it. Some patients have called it Chick-fil-A medicine because it's a quick in and out. They get what they need. And quickly. The staff enjoy it. They're not having to don and doff PPE, between patients. And so it's something that, and then finally, and arguably most importantly, is it could lead to decreased staff outages due to sick leave. I myself was sick 5 times in the fall and winter of 2019 pre-pandemic. But had been sick a total of twice during the pandemic, and in large part, I think, because I'm not seeing cough and cold inside. So I think there's some HR reasons to continue it, but not that everybody will or should do that, but it's just a reflection that we've kind of been thinking through as an organization. Should we do that? And we very well may. Other just reflections on what's happened and what should continue to happen in the future. We've improved our hiring onboarding process because of the pandemic and the pressure of it. And we're much more efficient, a well-oiled machine as far as our human resources department. We have multi-dimensional care, telehealth, chronic care management, things that we did not have before the pandemic. And I would say that our inter-organizational coordination relationships have improved. These are relationships with community partners. They've been strengthened. They've become more effective, really at producing change and addressing local healthcare issues that don't respect the organizational boundaries. Basically, well, we're able to affect change here locally. I think in a way that we were not able to pre-pandemic because of our strengthened relationships with our community partners, whether it's other clinic systems, hospitals, or the health district. Yeah, let's see, next slide. I think another thing that we've had some musings, like many organizations have, I think, is the pressure to provide COVID care and offload hospitals, make every diagnosis if we can, I think has caused some sort of soul searching as to how important is normal non-COVID primary care, things like UTIs, chest pain, wellness visits. And I think that we realize that it's more important than we probably realized pre-pandemic, because we've had to shunt some of our care to COVID care. And we just haven't had, unfortunately, the access to for non-COVID type care that we did pre-pandemic. I think you don't know what you have until you lose it, both from our standpoint as the healthcare personnel, but also from the patient standpoint. It's very important. It's very important to provide that non-COVID care. And just because we're not in an acute, hospital or ER setting, what we're doing is extremely important. And you realize that once it's compromised. People suffer when they don't receive non-COVID primary care. For the sake of time, I'm going to skip. I think I'm going to skip this this quick story, but there's a story of collaboration between us and the health district to provide vaccines from their supply of vaccines early in the vaccine rollout to one of the poorer zip codes where many of our patients resided. And so, but for the sake of time, I'm going to skip that. So I'll wrap up here. On a more abstract level, I think that there's been, precipitation in our organization of intra-organizational hierarchy and relationships that would not have happened had it not been for the pandemic. As I mentioned previously, some of our organizational chart and organizational roles and responsibilities were clarified because of the pandemic, realizing who needed to be doing what and who they were reporting to. Then also, I would say it really strengthened our relationships amongst one another. They're more functional, being in the trenches, I think has built them up, and people honestly speak more freely in boardroom type communication than they did pre-pandemic, because we just know each other better. We've been in the trenches with one another. People feel more free to disagree in a positive manner. And then I think that we're more adaptable and we're able to make quicker decisions. It's something that in my mind, I'm sort of calling organizational plasticity. So in conclusion, has there been change for the better? Well, certainly for the healthcare entities that have survived the pandemic, I think you can make the case that there has been change for the better. Certainly not in all aspects, but I think that the pandemic overall and from a certain perspective has been a refiner's fire and has made primary care more sustainable, certainly at our organization. All right, thank you very much.
Thank you, Dr. Wilson. Again, great presentation, really talking through the specifics and how do we navigate through the pandemic and balancing it with primary care or the expectation of primary care transformation. I really loved the way you ended it with the impetus or emphasis on organizational plasticity. I think this is an ideal time for us to hear from Dr. Bornstein to really put this into perspective on what does this mean for us as a state as we continue to navigate through the pandemic, but really continue to push the needle or move the needle on advancing primary care for all Texans. So would love to hear your perspective on what does this tell about statewide efforts and where do we go from here?
Thank you, Ankit, and thank you, Drs. D'Agostani, Dr. Chinvan, and Dr. Wilson. I think I can speak for the rest of our participants when I say that I am just so inspired, really, by the leadership that you all have demonstrated, by your vision and by your grit. That's a Texas thing, I think. It's a grit. You just get in there and you do it. I think you all really made it abundantly clear that COVID has presented many unwanted and unwelcome challenges, but based on your really insightful and instructive comments, it's clear that as high-performing primary care practices, you all really have incorporated the things that you have learned and really met the challenges head on. And it really truly is inspiring. So we hear a lot about the vulnerability of primary care, and I don't think that anybody would argue that that is not the case. I think our primary care system is very vulnerable, and unfortunately, or fortunately, maybe there is a silver lining. The COVID pandemic did really point that out in bright, bold light, if you will. And there's numerous reasons for that, as we all know. It's chronic underfunding, chronic underinvestment in primary care. Probably our fee-for-service payment system contributes to that as well. And those things really have served to weaken the foundation of primary care, which is, as we all know and accept, the foundation of our healthcare system. But Again, I think that you all have shown that primary care can and does step up to meet the needs of our patients and our communities, as well as your employees. And so again, I keep saying inspired, but I am really quite inspired. So I have had the opportunity to take a bunch of notes. I certainly had the privilege of reading the slides before, but hearing you all present them certainly gave it even more context. But what I want to do is just to give some reflections from what you all have said, and I have taken the liberty of dividing them into several different buckets, if you will. And the first thing I think that I hear is commitment. The commitment to your patients, the commitment not to disrupt that critically important relationship between primary care clinician and the patient, and to your communities. You know, you all live and serve in different communities, and you know that your patients and your staff, and you live in those communities. So your commitment to your communities, to your patients, to your staff, your commitment to the safety of your patients and also of your staff and yourselves. Very, very important. I thought it was very interesting when the ARC folks talked about the voluntary furloughs, that to me was an interesting way to deal with the challenges presented by COVID. I like the way Ben talked about, massively increasing staff hiring, and in response was like, there's a problem and we're going to solve that problem. We're going to address that problem. Another thing, and again, I think this may have been the first thing, was communication. Both organizations mentioned how important this is, and there's no such thing as over communication, especially when there's so many unknowns as there have been in this pandemic. I think ARC said obsessive commitment to communicating with all your stakeholders. So it's your employees, it's your community, and it's your patients as well. I like the huddle. I think the huddle, the 2 times weekly call with the physicians, very important, and it sounds like it was really key to continuing to be able to function the way that you want to. And, I think you have to all agree that creativity is another one. I mean, to go from 0 to 70% of your visits on telehealth in 10 days, I think you said, that is massive. That is massive. That takes great organizational discipline, creativity, and focus to be able to do that. And you all were able to do it, whether it's scheduling, the online scheduling. I love the outside tents. And I think, Ben, what you said was so interesting, that to think that you could really even incorporate that modality of seeing patients on an ongoing basis. So again, here we are. Here's this unwanted visitor, if you will, that has, done a lot of really tough things, unfortunately, high mortality and morbidity, but there are some silver linings, and the fact that it may give the opportunity to rethink how we deliver care is really quite a positive thing in my opinion. Also keeping up with the guidelines, how do you, that's been a challenge for everybody, right? But how do you keep up with those? How do you interpret those? How do you communicate those to your staff and to your patients? That is no small feat right there. And I think that continues as a challenge. Another thing was collaboration from both organizations, with other healthcare institutions, with the local health authorities. And what Ben didn't talk about, but it was in his slides, was the fact that that Waco Family Medicine recognized that one of their zip codes wasn't getting the allocation of vaccines that they needed, and were able to work productively with their local health authority in Waco to make sure that those underserved areas did get their fair share of the allocation. So again, collaboration and with your own teams. I think those are all very important things. Another quality that I see is compassion. And it is part and parcel, I think, of being any physician, but a primary care physician in particular. I think, Ben, you talked about the vulnerabilities that you saw in your organization, the vulnerabilities that you saw in your patients. that were exposed. You all care deeply about the mental health of not only your patients and their physical health, but you also care about the mental health of your employees and your staff, your physicians, your nurses, all the staff. And that was an important theme, I think, that you all, you're not there just to see the patients and get through the day. You're there to care. And I think that, to me, that theme was so prevalent. It really underlies everything that you all talked about. I think another C that I added during the talk was clarification. I thought that was very interesting too, Ben, about, again, here's this terrible thing that's coming to us, but we understand maybe that people weren't reporting to the right person, or maybe their job description wasn't appropriate or something like that. And so the ability to clarify roles, responsibilities, and expectations. I think, again, did we want this? No, but here it is, and let's kind of make the best of that opportunity. And I think the last thing, and so as far as closing, is really contemplation. You all are all reflective, thoughtful people. And so you clearly have had time, now that things have sort of, maybe, God willing, hopefully slowed down a little bit, to really be able to reflect on the things that you've experienced, and to how can you incorporate these experiences? How can they inform our practices, your practices going forward? I think, Ben, you said something towards the end of your comments that I think was very important, and that was about the importance of chronic care management. And when we had our pre-calls with both of you all, both organizations, that was one of the things that I was particularly interested in, was how do you do that? How can you possibly balance the need and the for people with chronic care needs with this acute pandemic? And so I think, again, going forward, even though Norm and Anas said we don't ever want to do this again, nobody wants to do this again, but if we do something like this again, I think we'll all be in a better position. And not only that, I think we'll be in a better position, again, irrespective of whether we have another situation like this. And so I just, again, I come away from your discussions and your presentations. I also want to thank you for being so candid about this. It's easy to get up there and say, we did this and we did that, but you all were very willing to share some of the difficulties that you learned, and some of the things that caused you to really have introspection about, well, maybe we need to do things differently. So I think, again, I speak on behalf of certainly the participants and our staff. Thank you for sharing candidly your experiences. And again, I leave this presentation inspired by your work and the work of your colleagues, and just really am very, very grateful for all of you and all the things that you do. So with that, I'm going to turn it back to Ankit.
Thank you, Sue. I mean, you really summarized this, and you are 100% on point when you recognize that this is really the feeling collectively, for sure, as a team, but I'm sure on behalf of all the attendees that, again, thank you for your leadership, and you have really let primary care shine. And Sue, love your summary of the C's that make up primary care. I was taking notes, so definitely we'll be using that as we move forward. We do have a few questions, and so I will hope to basically read this out and then throw it at one of you, but would invite each one of you to kind of share your perspective. We do have a couple that we have received during your presentation, and then a few that we had received in advance from attendees during registration. The first one, and I would just encourage everyone in the attendees that please use the Q&A option for sending your questions, but we did have one come through the chat, and I think it's putting in perspective. I believe ARC mentioned that we were capable or had the process for virtual visits even prior to the pandemic. Of course, that helped catalyze the transition more quickly and efficiently than other practices may have not been. And Dr. Wilson, you mentioned you were not prepared, but you had to make that switch very clearly in a very short period of time. The question is that now it's almost been 2 years that we have lived through this pandemic. How much of things remain as was the transition in March 2020, and how much of this has changed kind of going back to the pre-pandemic? I believe what we are trying to get to is what does the future look like as we continue to emerge from the pandemic? Will it go back to being all in person with virtual being small component? Would it be a balanced act, or does this get to the point where we have a paradigm shift in the way we may be thinking about delivering and coordinating care? So, Dr. Dagestani, Dr. Chenwan, if you want to go first, and Dr. Wilson, you can react or chime in.
Yeah, so I think, I think from a telemedicine perspective, we saw that peak at 70%. And with the slide that Dr. Wilson showed about the peaks of the pandemic, every one of those spikes had a telemedicine spike with it, basically. What we're seeing right now is it's leveling around 10 to 15% telemedicine and the rest in person. And it's specialty specific. In primary care, IM and FM and PD is holding around that level. Some of our medical subspecialties and surgical specialties really are getting close to zero, to be honest with you. And that's not us as an organization driving it. It's really patients driving it, basically. I do think there's a lot to learn long term, because right now it's a little bit more random. And I think we need to get to a point where we're trying to figure out the right condition and the right, specialty and the right physician. So, a cold on a telemedicine maybe is fine. Evaluation for chest pain on a telemedicine maybe not so fine. So I think we have to continue to fine tune what we do. I suspect telemedicine is here with us to stay as an extension to primary care, an extension to see the specialist, and probably will stay around 10% plus minus. So that's how we're seeing it. Norman, anything to add?
I would agree with the term random. Right now, I think we're so exhausted, we really haven't sat down and circled the wagons and tried to come up with a systematic approach for the future for telemedicine. Individual doctors are shaping their practices slightly this way, slightly that way. We find mostly with telemedicine, we're responding to a great degree around the payer recommendations or payer approaches, and that will challenge us if the payers go back to, well, telemedicine visit is not worth anything. We can't sustain ourselves. A telemedicine actually takes as much doctor time, very often, sometimes more, sometimes less, but and we have a mixed model. So it's not that, oh, well, you don't have to worry about the facility. Well, yes, we do. It's still there. We're still paying for it. And having the facility is a critical component to a really robust telemedicine program. Come in and get your test. We'll schedule this. We'll schedule that. So I think we don't know where it's going to land. I'm actually surprised at how quickly it came back down. I was personally predicting that it would settle out at 20 by this time, and it's really much lower for us right now. I do think that we have not worked on the chronic care aspect of telemedicine. We are starting to work on behavioral health aspect of telemedicine. My guess is, I think Anas said 10 to 15%. My guess is 5 years from now, we'll be at 20, somewhere between 20 and 25, but that's going to take work. It's not going to happen naturally. And it won't be there at all if the payer response is reactive and negative toward telemedicine.
Dr. Wilson, anything you may want to add?
Right. I mean, I agree with those comments. I think that there's some fine tuning that needs to happen as to the exact usage of telehealth. Certainly the low hanging fruit has been COVID telehealth and acute care. How can we really roll it out to chronic care and telehealth? I think it's sort of an interesting discussion. For this group or any group really in medicine is this kind of the crashing down of telehealth after a surge and in non-surge times, which we have totally experienced as well. There just doesn't seem to be interest in it. And I almost think that it's kind of like people have been in hiding during a surge and they're craving human contact. It might be as simple as that. We are human beings fundamentally, and we want to see somebody else, and we want to have that face-to-face, and our patients are no exception to that. What will be interesting, Norman, I think you mentioned 5 years from now, what will things be like 5 years from now when people haven't had that deprivation of human contact? Will everybody be embracing telehealth because they've had plenty of human contact lately? Say, oh, telehealth is more convenient than going in person. And I've been around people already for the last week, and so let's do it. But then there's other concerns. I think the question touches on not just telehealth, but, chronic care management, some of these other adaptations, clarification of roles and responsibilities within an organization, adaptability. So some of those sequelae of the pandemic, I think many of those are here to stay.
Yeah, and the technology is still not refined. It's pretty clunky. I think every day the doctors complain of frustration trying to make a clear, simple telemedicine visit without something going wrong. So we've got a ways to go. I do think, obviously telemedicine's in our future at some level. And I'd love to see it hit 20-25%. I think that'd be great for the patients. It's a real pain in the butt to drive into the doctor's office, wait, and that sort of thing. So I think we can do better.
And Norman, to your comment, the technology is not only on our side, because a lot of the challenges are actually technology on the patient side. Bandwidth, reception, all of those things. So even if we invest in everything on our side, if in the patient side they don't have the technology, that's been the challenge as well.
This is great, and I think again setting I would say it's the right balance between optimism, but being practical and bringing it to real life. So again, thank you for those perspectives. I think again there was a constant in between both of your presentation and experience was this challenges or opportunities with staffing and advancing primary care. So the question speaks to how much of the shortages, challenges that you observed, especially in the early days of the pandemic, still persist. But acknowledging that both of your organizations have not just sustained the staffing level, in many ways it has, you've actually added and grown through this last couple of years of the pandemic. There is also the challenge that comes along in bringing in new team members. So do you have any reflections to share? Dr. Wilson, if you want to go first, and then Dr. Chenwen Tagastani, would love to hear your perspective.
Right. First, our organization, we did a very particular thing because our deficit was in hiring. Ability to hire and retain was so deficient. We hired an associate director of HR. And so we brought somebody on specifically for this issue. And so I don't know how ubiquitous or how applicable our intervention was to other organizations. But so I think that for us, it feels like we fixed the problem, but at the same time, we brought this person on, and some of the changes that they implemented, we implemented those kind of more or less during the Omicron surge. And so I don't think that, and now that it's over, I think, fingers crossed, we don't have another surge, but it'll be a test for us to see how it goes. And I think it'll be a whole lot better, but we'll wait and see.
Well, so every business in the United States is struggling with staffing right now. There are some indications that that's going to loosen up, that people are going to be willing to come back to work. We'll see. I think in healthcare, we already know that we're tremendously under-resourced when it comes to primary care doctors. And I've heard estimates, crazy estimates, like we're 40,000 primary care providers short. That's a lot of people. That's a lot of providers. And we don't see that. That's not going to change in the near term. We did the same thing as Ben did in terms of recruitment. It was all hands on deck. We moved people out of operational positions to help with recruitment for staff. And we just did the best we could. I did misspeak or over exaggerate. We did close one clinic for, I think, 2 days when the 3 doctors and the 5 staff people all called in sick at the same time. There was just no remedy at that point. But I think the other issue that we haven't mentioned is that compensation. Our compensation has had to go up throughout the organization. That means our overhead has had to go up. Blue Cross is, when I give them a call, they're not particularly empathetic or sympathetic about that. So I think it's a real issue. Anas,
Yeah, no, I think you covered it well. I think, we're still tight on staffing. We're doing, knock on wood, reasonably well. Part of it is working on the culture of maintaining your own staff, keeping them engaged. Part of it is being more creative from work from home when it makes sense. But that's a double-edged sword. I think that's another thing we haven't talked about is how do we maintain, culture, maintain efficiency, maintain teamwork, and work well with work from home. That's another battle like telemedicine that at some point we're going to have to refine and fine tune to be good at what we do. I think telemedicine done well could take some pressure off of staffing, but that's probably 3 to 5 years away, not anytime soon. Right now, it's leading to actually more staffing and more investment into infrastructure. We're looking, at educational program within, ARC. Do we train our own medical assistant? Do we train our own phlebotomists? So we're working with different agencies trying to bring training in-house if possible. But I think we're in for a year or two of tight staffing for all of us, especially in primary care.
That's great. I think just to piggyback on this, like talking about finances, but Dr. Chen, when you also mentioned it in your point on telehealth and how the payers respond, and really what we are talking about largely is payment, the way it's in the current setup, but what it needs to be for this to be more of responsive and get accustomed to the dynamic situation that the pandemic has been a great example for. So I want to respond to this question and would love to hear your perspective as a result of this pandemic. Do you see acceleration towards capitated fee arrangements, including for community centers, or and if so, what is needed both from a policy standpoint, but also transformation standpoint?
So my soundbite is that fee for service is the original sin of American medicine, and it's really been very difficult to be flexible and respond to situations in that constraint. So you have to have multiple, very rapid visits, turnover, you're not doing the best job, and so on. I don't know. I think that every community, when you've seen one healthcare ecosystem in one city, you've seen one healthcare system in one city, and it's different. Just up the road, Waco is different than Austin. Austin's different than San Antonio. San Antonio is different than Houston. And we find that there's not been much of an appetite for capitation or pre-funding, which would be the ideal way, in my mind, to finance healthcare, to get organizations like our organizations on this call the flexibility and ability to reorganize the way we provide care. I'm convinced we could provide much higher quality at much lower cost and with greater service if we controlled our business, but we don't control our business model. And so I am not, at least for the short run, I'm not optimistic. There are employers, large employer groups across the country that are now talking about wanting to see capitation or wanting to see a primary care based capitated system. But I don't think they're well organized. I don't think that's going to happen. But it's the first time I've heard it in a very long career where the employers light bulbs are starting to go off, that the system is structurally set up to fail. And I think it starts with fee for service, and then you add in the third party payer system, and it just doesn't work very well.
Yeah, and what I would add to Norman's comment is there's a lot of appetite for capitation. Norman heard me saying that before, but it's in a form of decapitation, not capitation, where everybody, just want to quickly move the risk to primary care without the investment into one. This is a long-term journey. You can't fix it overnight, and you have to invest in infrastructure. You have to invest into benefit design, network, and all of those pieces. So I think, we hear a lot of interest in capitation, but everybody's looking for quick results by the end of the year. and understandably why, but I don't think we're going to fix this by always planning off what can I achieve by December 31st of 22. It has to be where we want to be in 5 years.
Dr. Wilson, any comments?
Nothing really in addition to what's been said, just that the person that asked the question specifically mentioned community health centers, and I'll just say that community health centers would love to have a capitated model as well, and we are all for value-based care, and we participate in some value-based care programs, and so any catalyst for that, I think any catalyst for it is a welcome addition. So.
Thank you, Dr. Wilson. I realize we have about 4 minutes before we get to conclude today's webinar and dialogue, but I would love to keep this ongoing. I want to be respectful of all of your time and those of our attendees who have joined us. But before I get to the closing remarks and wrap this up, I want to ask one final question that I'm sure Sue and I would love to hear your perspective is, we are talking about bringing the attention to primary care, but also lifting up the challenges and the real barriers, systemic barriers that primary care has to address every single day, not just through a pandemic. So if you think about systemic change and really bringing the attention of our lawmakers, what do you want them to know about primary care in Texas? And what is that one ask, if you have to make, that you would want to lift up?
I think Norman covered it. I think the payment system is the challenge. So I think and a long-term investment into transitioning the payment system, because the pressure on primary care is you have to see more patients and you have to document more and you have to do a lot of things in the same 8 hours that now turn into 12 hours. And now with inflation and rising costs, that's going to put more pressure actually on primary care to maintain the same level of staffing. So I think it's the lawmaker working with a health plan, working with the community to try and have a meaningful long-term change of the payment system. So I think that's one issue. The other thing is coordination, because I see a lot of examples where we're trying to solve one small problem. And it expanded to other areas. So, the No Surprise Act, for example, was started as a very noble idea to try and protect patient from surprise billing when they see an in-network hospital. And it morphed into this, monster where, we had a meeting last week. We almost have to, with a group our size, add 3-4 staff and we're not providing care. This is more to produce paper and estimates and things of that nature. So just, collaboration we have to restructure the foundation. And so far, we wanted to keep the same foundation, say, move the wall here, put the window there, and let's hope it's work. I think we have to get back to the foundation of the problem.
As a community health center, I have a 1A and a 1B on this. The 1A is what Norman and Anas said, and then 1B is if it's not too hot button to say this, would be Medicaid expansion. We have so many patients that are eligible for Medicaid where it's be expanded, and me personally, I'm not the authority at all on this, but me personally, even a sliding scale, based on ability to pay would be great. So there you go.
Well said. Thank you,
Definitely
Dr.
agree
Chairman.
with that.
Wonderful. Again, thank you again so much for joining us, for doing what you do every single day. Again, you are making a difference, and in many ways, the inspiration for us to do what we do here at the consortium. Again, thank you for your time. Thank you for your leadership. And for those of you who joined us today in this discussion, in many ways, we know you are advancing primary care for your community, for your organization, and we hope to be your resource. We will definitely be back with the next webinar, but the recording for today's webinar will be available. If you registered, you will receive a link. We'll also have an opportunity to respond to an evaluation, which will only help us inform our plans moving forward. But as every year, we will have our annual summit, and glad and excited to share that this will be our 10th annual summit. And at this time, we are planning for this to be in person in Austin, September 8th and 9th. We currently have a call for proposals that's open, and would love to hear from your organizations and the amazing work that's going across communities in Texas, and look forward to seeing many of you in person this September. Also, we really are your collective voice. So our voice is only stronger when you join us at the consortium, and there are many ways and levels in which you could support our work at the consortium. Please visit our website or reach out to one of us, Dr. Bonstein, myself, Stephanie, Katie. Just feel free to reach out, and we'll be more than happy to jump on a call, answer any questions you may have, or send resources your way. And Sue and I have the privilege to be the face, but we cannot do this without an amazing team. Again, a special shout out to Stephanie as our Chief Convenings Officer at the Institute, and Katie in supporting, but duly supported by our communications team with Megan and Kaneka leading the charge. Again, on behalf of this team, on behalf of our partners, thank you for doing what you do, and thank you for joining us today. We'll see you soon. Take care.
Thanks so much.
Thank you all.
Stay well. Stay safe. Thank you.
Thank you.
Take care.